So welcome everybody. My name is Natasha Bolaños. I'm here on behalf of Lymphoma Coalition. Lymphoma Coalition is a global network of 83 patient organizations from 52 countries working on the lymphoma space. And I want to welcome also my co-chair and really one of the initiators of this project, Susan Thornton, who in addition to being the current CEO of the Cutaneous Lymphoma Foundation, has been living with cutaneous lymphoma for close to 30 years. So the intimate knowledge Susan has of what it's like to live with this rare and incurable disease makes her probably one of the best voices to speak on behalf of the patients. Before starting the meeting today, I would like to share some housekeeping rules. The first one is today's webinar is being recorded and will be available through the EuroBloodNet YouTube channel afterwards. During the presentations and during the interview we will have later with Susan and Ketura, we will appreciate if you switch off, the audience switch off the cameras and the micros, not to interfere, and for everybody to focus only on the speakers. For questions and answers, you can type your question in the chat box at any time, but we will be taking the questions at the end. And now let's see the scene. Cutaneous T-cell lymphomas are rare diseases with an annual incidence of around 10.2 per million person. And this is a very special day for us because we are coming to the end of a series of webinars that we have been working on, first for clinicians and later for patient organizations. And the topic today is so important because we cannot talk about treatments providing efficacy without considering the impact they have on quality of life, on patients' well-being. At the end, it's not only how much days we put in patient life, but how much life we can put in those days. So for talking about this topic, our first speaker is Professor Pietro Quaglino, dermatologist and associate professor of dermatology at the Department of Medical Science and director of the residency program in dermatology at the University of Turin. Professor Quaglino is highly interested in cutaneous lymphoma, but also in melanoma and immune dermatology for both research and clinical practice. He has huge experience in the field of cutaneous lymphoma, ranges from the early diagnosis to the treatment of the advanced phase of the disease. He has been the principal investigator of several clinical trials in melanoma and cutaneous lymphoma. He is past chairman of the Eurordis Cutaneous Lymphoma Task Force and has been member of the board of director of the International Society for Cutaneous Lymphoma, among many other key positions. His passion for research generated more than 200 peer-reviewed scientific papers, and it is a real pleasure to welcome you and to give you the floor. So you can start your presentation whenever you are ready.
Thanks so much. Really, thanks so much. I will heartily thank you for the possibility to be here and for this very kind and sweet introduction. Okay, the important point is to be here to discuss with you and share with you challenges and issues related to quality of life, which are of fundamental importance in the management of this kind of disease. So many thanks for this possibility. And I think that I can start and share my screen with you. And after the presentation, I will be available for any kind of questions and comments and suggestions that you may have. Okay, today my topic would be, while my slides become, I think that you can see them, but I'm trying to put it in full screen. My topic is impact of treatments on quality of life. Okay, I think it is good. Okay, and this is my summary. So I will start by defining what is quality of life, how do we measure quality of life, and then important point, whether or not, and unfortunately yes, is impaired quality of life in CTCL patients, and then data on quality of life in published trials and in ProClipI data together with ongoing studies. So which could be an operative definition of quality of life, because as you can imagine, quality of life is a large concept with different potential definitions according to different situations. But for sure, what is related to disease is health-related quality of life, which focuses on aspects of patient quality of life in the context of illness and treatment. And since this definition is important to consider that quality of life is related for sure to disease, but also to treatment, which can also impair or worsen or improve quality of life, depends on response and safety of this treatment. And for sure, health-related quality of life represent a concept that includes several different areas which all together participate to definition and existence of this quality of life concept, which are physical, which are psychological, functional, social, and emotional well-being. So how can we define quality of life related to health issues? Basically, a very simple but important definition is the ability of the patient to enjoy and to continue normal life activities in all the kind of these activities are, for social, for working reason, whatever. And for sure, quality of life is important. And as I already told you before, there are this double connection between disease and treatment. Disease for sure impairs even severely quality of life. And for sure, as you know, if a disease starts and develops in the skin, the risk of impairment of quality of life is even higher because the disease is visible and can induce pain, itching, whatever, but particularly is visible from the patient and from other people. But also, as an important second point, medical treatments can impair quality of life. An example is chemotherapy. In the fields of cutaneous lymphoma, we use very rarely, and we are using more and more rarely chemotherapy with respect to the past years, to the presence of new drugs, because even if can be active in terms of clinical response, the response usually does not have a relevant duration, and moreover, there are significant side effects. So the problem is whether a treatment can impair quality of life without providing appreciable benefits. And we are lucky that in the recent years, we had the possibility to develop new trials that put together clinical activity and improvement in quality of life. So quality of life is not defined by medical doctors, is a patient-reported outcome. So it's reported and defined by patient, and usually measured with instruments such as questionnaires or touchscreen technologies in this era of modern devices and computers and whatever. And in the last years, we had a great possibility, and we all agree, to incorporate this assessment into the evaluation of treatment efficacy. So it's not only treatment active because of gives responses, but also important whether or not induces an improvement in the quality of life. And so quality of life issues can be used in clinical practice to monitor the impact of disease and treatment, and also to provide evidence for the evaluation in the quality of healthcare and informing clinical and health services decision making. So it's an important point which has important reflection in the daily clinical activity. So if this is a definition, how do we measure quality of life? We have different questionnaires, but basically we have two types of different questionnaires. One is dermatologic specific quality of life test, and the other cancer specific questionnaires. And for sure, dermatologic specific quality of life test deal more on the sphere of cutaneous lesions, whilst cancer specific questionnaires are more focused on the impact of cancers and all type of cancers on well-being. It's important to consider that either evaluating dermatologic specific quality of life test or cancer specific questionnaire, we don't have a specific questionnaire for primary cutaneous lymphomas. We are working on this, and I will show you in the last slides of my short presentation, but at the moment we don't have a specific questionnaire for primary cutaneous lymphoma patients. And this is important for future issues to have this for evaluating this kind of disease. Just to show you, probably you are familiar with this. This is, for example, the Skindex questionnaire, which includes a number of different questions. There's no need to read all of this, but basically, as examples, my skin hurts and my skin condition affects how well I sleep. I worry that my skin condition may be serious. And each patient can evaluate this issue considering his or her specific situation simply by showing what is his or her specific feeling, and so never, rarely, sometimes, often, unfortunately, all the time. And these different responses have a value from 1 to 5. So means that if a patient has a severe impairment in quality of life, this patient will have a higher value for his or her Skindex questionnaire. Okay, so higher values mean lower quality of life. And these are all the other questions that define this questionnaire. The other cutaneous specific questionnaire, even if there are these small characters to show you all the question, is the LQI, which again define different questions about symptoms, daily activity, leisure, work and school, etc. And then, as you know, very much, lot, little, not at all. Again, 3 for the points related to higher impairment of quality of life. So it becomes clear that there are different questions, but we have 3 different burdens that we can evaluate. So one first related to symptoms like itching, burning, pain, irritation. The other about emotions, worried, embarrassed, frustrated, depressed. The other is functioning. So how skin disease can impair the function of your skin and your body in the normal daily activities like work, sleep, and etc. So all these questions deal with these 3 different kind of involvement to quality of life in daily activities. This is another question, ERTC QLQ 30, which is on the other hand a questionnaire generic for cancer. And as you can see here, the questions are not related, or not the majority related to skin, but generally, do you have any trouble doing strenuous activity, long walk, or were you limited in doing your work or other daily activities? So it's more related to cancer in general. Okay, so my third point is is quality of life impaired in patients with primary cutaneous lymphomas? And unfortunately, the response is yes. And I will show you briefly two papers which focus on this issue. The first one is a very recent and comprehensive review. So it's a paper that analyzes all the papers published in the literature, summarizing the results and thus making general consideration about this topic. And which are the conclusions of this paper, and thus as a general situation in CTCL. The effect on quality of life was found to be greater in patients with late-stage disease. It means a patient with disseminated plaques or tumors or extracutaneous involvement, as expected, can have a higher impact of quality of life with respect to early stage. And this is true for the different burdens of quality of life evaluation, thus functional, emotional, and physical domain. But what is important is that also patients with limited disease, some patches or plaques on the skin, so early phases, so not so large involvement, quality of life is impaired, mildly or moderately, but impaired. That is an important point to consider, and I will show you some slides about that, and also the importance of incorporating quality of life evaluation in the definition of the clinical activity of treatments. Overall, pruritus was the most frequent reported symptom, and significant influence of the disease was found not only in patients, but also in caregivers and family. And this is another important point, because caregivers and family, who are the members that are close to the patient, for sure, have all the same problem in taking care of the patient and can have an impact on their quality of life as well. And the second paper is this one, which reports preliminary data from a large registrative database which is ongoing, which is ProClipI. So all over the world, we are collecting new diagnosis in mycosis fungoides and Sézary syndrome from different countries, putting all the data together to collect large number of data to improve our potential to understand disease course and to help patients and to manage in a better way this disease. And so the conclusion of this preliminary data are that analyzing Skindex, so the question that I show you, that there is an impairment of quality of life, and this is particularly important in late stage patients, in female with respect to male, and this could be discussed, and in patients with greater cutaneous involvement. And SWOT is a criterion to define which extension has the lesions on the body. So higher is SWOT, higher is the extension. So it identifies thus specific characteristics of patients that are related to higher risk of quality of life improvement. So late stage, female, and increased skin involvement. So what about quality of life in published trials? And as I told you before, we have now the possibility to have new drugs, in particular in Italy and Europe in the last years, 2 new drugs, very active, more active than previous drugs, and also with a more favorable profile in terms of toxicity, were approved. One is brentuximab vedotin, and the other is mogamulizumab. Apologize for the difficult names. So let's analyze the data on quality of life in the 2 trials that allow the registration of these drugs. Brentuximab vedotin was approved thanks to the results of this trial, which is the Alcanza trial, which compared the brentuximab versus other treatments, best clinical choice, which were methotrexate or bexarotene. And this is a little bit outside the quality of life issues, but also I think it is important to show you how we are considering the clinical activity. For example, this trial was important because it has as primary endpoint ORR4, which is the percentage of responses over a response rate, the percentage of responses which lasted for at least 4 months. So it is important not to capture only the response, but also the duration, because sometimes, unfortunately, there is a response, but it's short-lived. So we want to check if this drug can induce long responses with a longer duration. So this was the reason why we selected this ORR4. And the other important point is that in the key secondary endpoints, but it's secondary, I mean, for the study, but it's relevant for sure, there is the rate of complete response, the outcome of the disease, and the patient-reported outcome. So measure of quality of life using Skindex. And for sure, brentuximab vedotin induced an improvement with respect to the control arm for all these endpoints, and in particular also for the Skindex symptom domains, with a significant reduction, so an improvement, because if you remember, in the presence of higher values, there is higher quality of life impairment, so there is a reduction, and the reduction was significantly higher in patients treated with brentuximab with respect to the other patients. And here you see a little bit small pictures, but if you can see and focus on this, in red is brentuximab, in gray is the other arm, and you see there is a significant benefit in all the domains that you see, so the total score, symptoms, emotions, and functioning. Functioning, the difference is a little bit smaller, but again significant. And also this that you see on the left is another important analysis that consider patients with neuropathy, so as side effects, which did not have worsening in Skindex 29. The other study was Maverick, which allowed the registration of another drug, which is mogamulizumab. Again, the study was randomized against another drug, which is vorinostat. Again, the primary endpoint was progression-free survival, but again, patient-reported outcomes were included in the endpoints. The study was positive, so MOGA was superior to the control arm. And also, we can skip this, and also about Skindex analysis, these are a little bit complicated graphs, but considering MOGA in red and vorinostat in black, you see that there is a more significant change from baseline. So there is a change, thus a reduction in Skindex, so an improvement in quality of life, which is more significant with respect to vorinostat. And also, as you see here, the time to symptom worsening, so the time when symptoms unfortunately worsen is more is longer, and you see we have a lot of more patients that have no worsening of symptoms with respect to vorinostat. So this drug can induce a significant impairment also in quality of life. Besides clinical trial, also ProClipI data consider with very carefully this issue. As I told you before, ProClipI is an international database, and we had the possibility to analyze the impact of different treatments in quality of life. Okay, and this happened for early stage disease and advanced stage disease. Firstly, what about early stage disease? This is a summary of the treatment performed, early stage, so patches and plugs, all frequently limited. The majority of treatments are constituted by skin-directed treatments or phototherapy. And we had the possibility to check for skin index analysis in a part of patient 121 before and after the first line of treatment. So this is before. So these are early stage patients. As you see here, considering values before treatment, around 32%, so 1/3 of patients, had values that were consistent with moderate or severe 20% impairment in quality of life. So it means that 1/3 of patients with limited patches and plaques can have a moderate 20% severe impairment in quality of life. And you see are the patients above these red lines. What happened after treatment? Global before, global after, there's an improvement in skin index values. And this happened for all the domains, so symptoms, emotions, but not functioning. So the burden of quality of life impairment in this patient is more pronounced for symptoms and emotions, but it's very important because symptom means itching, pruritus, burning, etc. And emotion represent daily emotion related to quality of life, whilst functioning, so how the body works is not less impaired. Another important point is that for sure this treatment gave a response, clinically evident, but sometimes we can see also that even in the absence of clinical response or reduction of lesions, so in patients with stable disease, there can be some reduction in skin index, so an improvement in quality of life. And this is important because we have to consider this and reflect how we can evaluate response, because if I have a patient with limited lesion without an improvement clinically, but with definitely important improvement in symptoms or in emotions or in quality of life, this could be a good response. And I think that time is running fast, and these are my last slides, also for advanced cases, so more severe prognosis and also severe impairment. You see new drugs, as you see here, in all the domains, and here also functioning, because if we have erythrodermal tumors, the reduction in these lesions imply a significant improvement in quality of life. So treatment can induce an improvement in quality of life. I think that we can skip this, which is a little bit complicated. And just to conclude with this important ongoing study, which is a study done within the Eurordis Cutaneous Lymphoma group in association with the help of the quality of life group of the Eurordis to try to develop a questionnaire of quality of life specific for cutaneous lymphoma patients. There are different phases, and I am happy to tell you that there are 3 phases, 1, 2, 3, and we have now completed the first phase. So we have included a number of patients, and we have analyzed quality of life according to standard questionnaire to identify the issues specific for cutaneous lymphomas. And we are ready to move towards the second phase. And we have recently published, thanks to the leading group of Birmingham, Professor Julia Scarisbrick and his co-worker Kevin Molloy, and the collaboration of other people throughout Europe, presented the first results at the last Eurordis meeting in Marseille a couple of days ago. So this was my last slide. Many thanks to all of you for listening, and I'm available for all your answers, for all your questions, to answer to all your questions. Sorry for that. Thank you.
Thank you very much, Professor Quaglino, for this insightful lecture. Susan, we thought we were taking questions at the end, but if you were having an interview, you prefer to do it differently, or?
Well, let's see. I think
we have time, so I'm available.
Yeah, or we can do why don't we do the interview with Keturah, and then I think it will,
unless there is a burning question, and I don't think so, because we don't
we can have the two
perspectives. I think that will be good. I think
fantastic.
That will be good. Yeah.
So
thanks to Keturah so much. Happy to see you.
Thank you. Thank you so much. Thank you for your presentation.
After this insightful lecture, it's time now to welcome Keturah Harris. Keturah is an award-winning inspirational author, business consultant, and career strategic. Keturah holds an MBA in change management, as well as certifications including human resource management, spiritual care, and psychotherapy. In the words of those who know her well, Keturah is a top-notch consultant, coach, and mentor, has a dynamic personality, and it's a leader with presence. She possesses depth of experience and knowledge in a wide range of areas, from business and strategy development to career consulting. Her passion for developing people and the quality of her work are an inspiration to many. And I think that we are very lucky to have her with us today. I now call upon Susan Thornton, who will be having an interview with Keturah Harris. The floor is yours.
Thank you, Natasha. And it's such a delight to have Keturah with us today. And gosh, there's so many different places we could go, but I think jumping off of what Professor Quaglino had talked about on the clinical scientific side of capturing the importance of quality of life, I think, Keturah, maybe where we can start is a synopsis of your journey in living with cutaneous lymphomas and kind of what it's been like from the patient perspective and the impact on your quality of life, dealing with the treatments and ongoing disease management, and how that has played a part of how you've gotten to where you are today, because your journey has not been an easy one. So I'm going to let you share a little bit about your experience and perhaps some of the other components of quality of life that don't necessarily get captured within that clinical, very clinical, numeric component, if that makes sense.
Sure. Thank you, Susan. A delight to be here, and thrilled that this work is going on. So grateful that this work continues, and I believe that it will have an impact on patients and clinicians as we work with patients moving forward. I'm coming to you from Canada, and it's morning, so bonjour or buongiorno, and I was diagnosed with MF back in 2013, September 17, 2013. It was the day after my 47th birthday, so it was quite the gift. For 7 years prior, I had been misdiagnosed with atopic dermatitis. And that was a period which I would describe as hell, because I had chronic itch, pruritus. I had sleepless nights for 7 years. And I also lost my hair. All of this combined with the long-term effect of sleep deprivation does not actually affected me both personally and professionally. The domains of quality of life that I kind of pay attention to are the physical, what's happening to me physically, and also what's happening to me mentally, emotionally, socially, economically, and spiritually. So those are the things that matter to me that I kind of track as I look at my journey with the disease. When I was diagnosed correctly in 2013, I immediately began phototherapy. And phototherapy, I did PUVA, is quite a demanding process. It doesn't seem like it at first, but it is a demanding process. It takes a toll on you.
It implies that you have to go several times to the hospital. Yeah.
Absolutely. And when that hospital is an hour away from you and you are working full time, it's quite the challenge. So very demanding. It's also tiring. So I don't know if the tiredness comes from the commuting or the actual increasing treatments themselves, but it's tiring, there's burning, there's discomfort. So that was part of my early introduction, as well as some cortisol creams. We stayed topical until the disease progressed within about a year and a half. And again, in this time, as it's progressing, as tumors are developing, we had to take a look at some of the bigger pieces like radiation and immunotherapy. Those were game changers for me in terms of my quality of life. Physically, the toll was impairing. I like that word impairing. We use the word disabling a lot, and my doctors described it as disabling. The energy, the immunocompromise, the disfiguration that the disease itself was causing, as well as the treatment of the wounds that were developing, all of that was very demanding on me and quite exhausting. In addition, socially, skin conditions tend to be stigmatized. So having visible disease became a very socially isolating experience. And as we're seeing, even with the pandemic, social isolation is not good. It does take a toll mentally, resulting in myself moving from a very extroverted person to a very introverted person who was very anxious. It's traumatic. And so trauma was the term that my therapist would use in terms of how I was coping with and needing to grow from this disease. In addition, economically, it was disruptive because now suddenly the work that I did as an author, as well as a consultant and a counselor, I couldn't do those in the same ways. Personally, I couldn't show up. I couldn't be in crowds. I had to socially distance. Many of the COVID protocols that are put in place are protocols I was practicing prior to the pandemic. And so that was pretty crushing socially and would probably be pretty profound on the Skindex. And the cost of treatment began to climb even as my income began to fall. So that in itself can lead to a lot of stress, a lot of anxiety, a lot of wanting to push and take on work at times when really the focus needed to be on healing, recovery, and trying to get the disease under control. And spiritually, it was a crisis of faith. And my belief system was shaken. I'm thankful to say that it was deepened, but it was a process of taking a look at, well, what do I believe? Why am I here? It was a crisis of existence. So I think that begins to address some of what you're asking, Susan, in terms of, some of the kind of global impacts that a disease that I was told wouldn't change my life at all. That's what that's what I was told at the beginning, became a disease where the radiologists stood with a team of interns over my naked body and said, this is the most horrific form of cancer that we deal with because it is so visible.
Wow. Thank you for sharing so vulnerably your experience. And I think those pieces, and many of which I can also relate to given my journey as well with tumor stage and working full time and trying to navigate all of those, keeping your life together, right? While you're going through a disease process that is not only frightening, but physically impairing. So, and I think that is one of the challenges as we look at capturing this bigger picture of quality of life, right? And looking at an individual going through the journey in that full wholeness of personhood place. You know, we can capture the data of quality of life, as Professor Quaglino pointed out, which we're trying to capture. That really is helpful. But I think there's this whole other component that you can't capture in a survey at a moment in time, right? And we've got to find a way to understand the patient journey, which is different for everyone, but there's some similar threads. And how do we best support and help people navigate through that? Because there's so many unique pieces to this disease, as you mentioned so beautifully. It's the psychosocial, and I know you and I have both experienced the hair loss. And for women, I think in particular, and maybe for men as well, but I can only speak from a female perspective, but that is a devastating experience. Like, I think that was one of the worst things.
I agree. If I can make a comment, I don't want to interrupt you. I have to say that really was, I mean, I have to say that I really was an extraordinary and moving testimony of the disease and the problems. And I think also important to understand which are the most important point that we have to improve in the management of this disease. As you mentioned, the difficulties in diagnosis, which is a very important point. And then the treatments, you mentioned phototherapy. You know, phototherapy is not a treatment that induces side effects, very important side effects like systemic. But as you see, and as you witnessed, it's difficult because it takes a long time to come to the hospital and to come back and induce fatigue. And so it's important how to also such like treatment can induce an impairment and difficulties in the daily activities. And so the point to have, I mean, phototherapy is active, so to try to increase the places where it can be done, or increase also the fact to give the patient possibility to have phototherapy at home. I don't know if in US and Canada is possible. In Italy, it's really difficult to have through the national health system. And also an important point considering the question from Birgitta, thanks so much. Is there any research done on the influence? No, unfortunately, no, but it's important, and we are understanding also importance to have a psychologist for our first evaluation, like in other, like for other situations important with quality of life impairment. We are understanding the importance of having or asking for a psychological consultation, not because we consider, I mean, there's a difference between psychological and psychiatric. Sometimes patients don't understand. Psychiatric is related to psychiatric disease, but psychologically it's related to quality of life. There are no data, but I think, for example, in Italy, the first visit of a patient with primary cutaneous lymphomas as well as other oncological disease implies the presence of dermatologist, of a nurse, and the psychologist who is available then the patient can decide yes or not now, because also I think that you need, I mean, we are available for helping patients, so it's really very, very important.
Absolutely. And I just to kind of add to that, I don't believe I would have continued life without mental health support through a psychologist.
Okay, that's an important point to teach us how to work. So it's a very important, a very marked feeling that you have.
Yeah, I do wonder how many we lose to the disease, not because of the disease, but because they decide that life is too hard with this disease. So,
and now the situation is better. Oh, I hope.
For me?
Yeah.
Oh, well,
because I was worried.
Well, the fact that I can be on camera today is a good thing.
Okay.
Yes, I've been, interferon did a wonderful job of dialing it back from large cell transformation.
Okay.
So that was a gift. And then that gift kind of went away as it began to have negative impacts on my blood. And the drug became no longer available.
Okay.
Yeah. So I now have a home phototherapy unit.
Okay. Okay. Great. So it's important the activity of combination as you read is also to put different drugs together and see and identify the best combination for the disease manifestations.
Right. I'm on a retinol as well as the phototherapy, and we're seeing if that's going to make a difference moving forward. And yeah, and a lot of prayer.
Great. Wonderful. You're perfect. Okay.
Yeah. And Natasha, you had a question around the quality of life, because I know we're coming up to the top of the hour, and I'm sure we could have this wonderful conversation for a long time, because there's a lot of things to talk about. Yes.
We just started.
This is just the beginning. But Natasha, you had a question with regards to the different instruments and how these can be compared. And
yes, I mean, I wonder. I mean, if we have such variety of instruments, and this makes it really difficult to compare data directly. And the assessment of the psychosocial concept is not yet a standard in routine patient care, at least as it is required within clinical trials. No, so how we, I mean, the patient advocacy community could work to ensure that those small but relevant differences in these measurements coming from different treatments could be identified and registered properly in order to get evidence on how we should prioritize treatments, those with the best impact on quality of life for being used in clinical practice.
Yeah, I completely agree. I think that you mentioned a very important point. So the fact that at the moment this evaluation of quality of life are used in clinical trials, but not so frequent or not so often in daily clinical practice, and this could be, on the other hand, a very important point. And what is becoming clear from the data of Proclipi is that there can be no clinical response, as I mentioned, so stable disease, but with improvement in quality of life, and this is clinical response. So I think that we should, and we are working on that, try to, to incorporate quality of life and so patient-reported outcomes in the group of parameters that need to be evaluated for the identification of clinical response. If this happens, so also in clinical daily practice, there can be this kind of evaluation always, which is important. And also on the other end, I think that we have to work, and you're working also in Italy and other countries to consider that to add the quality of life patient-reported outcomes in the parameters that need to be checked during a clinical patient visit. I think this is important. And I agree that it's impossible to compare the different type of questionnaires. It's really difficult because there are a lot of questions, etc. They all give a general impression. I think that it's important to identify a specific questionnaire for cutaneous lymphomas because this kind of disease shares some features of clinical cutaneous disease, and also, unfortunately, is not an inflammatory, but it's an oncological disease. So we need to put this together. If you have an homogeneous instrument to evaluate quality of life in this patient, I think that this could be an important point to evaluate in a homogeneous way these issues.
Yeah.
But
There's
I think
so
the
much.
important is to incorporate this in the daily activity. And this is not easy because, as you know, there are a lot of problems related to visit, number of patients, etc. You know perfectly how things are, but I think this is more important it's important to see all the patients with an adequate quality in terms of, clinical, but also all this quality of life. So I think it's so important to incorporate these quality of life issues in the daily management and not only say, how are you? Are you fine? Okay. That's too simple.
Right.
I agree. And then measure pressure. Okay, blood test everything is nice, but this is important.
We have a lot of work to do. Brigitte has some questions, and Brigitte, if you want to jump on and ask, open your microphone, that would be fine too. But she's asking about how can we stimulate more quality of life research, not related to the introduction of new medicines. And I think, there's a lot of work going on behind the scenes at individual institutions, and we had quite a few presentations over the weekend at the European Scientific Meeting on Quality of Life. I think being able to bring all of those together rather than individual institutions to come up with some collaboration of data, and then as Natasha noted, our Lymphoma Coalition annual patient survey, which is coming out, I'm going to do a plug, early next year again, we had over 500 cutaneous lymphoma patients respond to that, which is, I think, different data from the patient perspective, not while they're sitting in a clinic answering a survey, but as they have the opportunity to answer some of these questions related to quality of life, gives us a different lens. And if the more patients from around the world we can have answering those questions, the more data we can capture and look at trends, and then be able to correlate that with the work that's being done on the clinical side through the Proclippi, through the other individual surveys, as a community of both patients and clinicians and researchers to say, how do we do this better? How do we help patients manage better? How do we understand what some of the impacts on quality of life are that may not be targeted at the clinic level? Brigitte, I'm gonna.
No, it's okay. It's a difficult point. I don't have an answer for the question how we can do. I think for sure we have to work together. Basically, I think that this is a very rare disease. I think that it is not possible to treat patients in all the centers, but we have to identify referral centers, and we already are. So if this referral center work together on the basis of institutions like UTC or ISCL or USCLC, together with patients association, this could be the basis for define consensus papers that clearly state this. And this is the first point, because if you have consensus papers, we have guidelines, and then we can do all the other things and up and after. So work together as organizing this and discussing together and sharing evidence and witness, like this beautiful that I heard today by Keturah Harris. This can really help in identifying this important need.
Yeah.
Well, I think we are running out of time.
Sorry.
So I don't know if you
always.
have any other burning questions, Susan, Pietro, Keturah, or anyone else
or
wants to
Enzo,
have a last.
Giuseppe, or Keturah, is there anything that you would like to share from the patient perspective that may be of help to other people as they navigate their own challenges through quality of life? And I know you've done a lot of things to help yourself manage, and I think that might be helpful for some other folks. Maybe that's a good place to finish up.
Right. I think it's good to know that there is help, that help is available. There is psychosocial support available, and sometimes patients do well to advocate for themselves, because I did fill out the quality of life survey, but nothing happened from that, right? So sometimes I really think it's important for patients to know, gather a team, assemble a team around you. You probably will need someone to help navigate funding for some of the treatments that you might be involved with. You may need someone to help do peer-to-peer networking. And that's where the Cutaneous Lymphoma Foundation has been life-saving for me, because resources that I didn't know were available were suddenly available for me to see and for me to explore. And I knew that there was hope. Understand that research is going on. So important, because you can feel hopeless in the disease, especially when a treatment fails. I think that establishing a standard among practitioners that it cannot be just a one and done. It's not just a dermatology issue. It's not just an oncology issue. It's also a nutrition issue. It's also an economic issue. And it's also a mental health and spiritual supports. And whatever that may be for someone, deepening those, because knowing that your life matters is a really good place to operate from. And because if we don't have our why, it's really hard to proceed with the what and the how. So knowing that our lives matter and that each patient is more than their disease. They are whole people living whole lives, and we need to attend to all of that. Maybe not ourselves, but point them in the direction of resources, foundations, associations that they can connect with, who have the relevant information to help them on the journey. Been life-saving for me.
No, I completely agree, and thanks to the work of the Cutaneous Lymphoma Foundation, indeed, we don't have, as my friend Enzo Bottazzi, we don't have such kind of primary cutaneous lymphoma patient association in Italy. It's related to rare disease. For example, we have psoriasis, a patient association, atopic eczema, but not association of this kind of disease.
We're working on that.
Yeah, we have to work on that.
We're going to work on that. And Brigitte's from the Netherlands, I believe. So they've established the Cutaneous Lymphoma Foundation there in the Netherlands, which is wonderful. And I think as we are expanding this global network of connected patients around the world,
would be a good point to work together, Susan, available.
Right. And really to share and find collaborative ways to work together to serve patients wherever they may live. And we just exciting to work with the lymphoma group in France on Saturday with the clinicians. We did our first ever fully patient education program delivered in French with all the French clinicians, which was wonderful. And we're looking forward to doing the same in Madrid next year. So as we're expanding this, and we're going to connect with Enzo and the group, the lymphoma group in Italy, to see how we can help support patients there.
Could be great. We can work on it for sure.
Yeah, it's a collaborative effort, and we're all in this together. So I think I'm excited where we're headed. So Anyway, and I know we're out of time, as we always end up out of time, don't we, Natasha?
Yeah, fantastic.
Never have enough time.
In pushing things forwards, it's always important to push forward.
Exactly.
Okay.
Very grateful for you all. Thank you for having me. Thank you.
I'm really grateful to you for your words and what you told us today. It was really very, very important for me.
Well, I cannot imagine better way to end this series of webinars. Thanks for your inspirational insights. I think this has been another very good, very informative and motivational session. And I want to thank everybody on behalf of EuroBloodNet, Eurordis, the Cutaneous Lymphoma Foundation, Lymphome Espoir, and Lymphoma Coalition. Congrats to all the speakers, to all the people working behind the scenes to make this program possible. And please don't hesitate to get in touch with us, with Cutaneous Lymphoma Foundation, with Lymphoma Coalition for any further question. And we will be working on, I don't know, Susan, we should try to bring a follow-up.
Yes.
Of this, probably targeting how we can use the patient evidence to improve clinical practice. So let's discuss further.
Yep.
Thanks to all our audience for spending this hour with us.
To see you in presence in Madrid.
Exactly.
Or
before
somewhere before. Okay.
Okay. Bye.
Thank you.
Bye bye.
Bye everyone. Thank you so much.
Have a nice day, nice evening.
Bye.
Bye bye.
Till next time.
And so ciao.
Yes.
Ciao a tutti.
Goodbye, Mr. Dr. Professor Baldino. Goodbye.
Bye bye. A presto.